all so much for joining us. My name is Erasma Veras Monticholo, and I am your host for Powering Up with Power of Two Facebook Live series. The goal of our series is to engage with community leaders, residents, and advocates to talk about the pressing issues facing families and children in New York City, and the steps that we can each take as individuals and as a collective to ensure the health and well-being of our communities. As an organization that partners very closely with families, we have seen all too clearly the toll that the pandemic has taken on our communities and the deep concerns and questions that many of us have about the vaccines, its development, and what it means for us and our families. Many of these concerns and questions are rooted in historical health inequities and injustices, which our families and community members have experienced firsthand, and which continue to affect the quality of healthcare we receive or do not receive. In today's conversation, we will look to provide our communities with answers to their very pressing questions about the vaccines and the distribution. Our guest today, as you all know, was to be Dr. Torian Easterling, the first Deputy Commissioner and Chief Equity Officer for New York City's Department of Health and Mental Hygiene. Unfortunately, he had a last-minute conflict which precluded him from being here today. However, Dr. Easterling connected us with his trusted colleague, Dr. Julian Watkins. Dr. Watkins is a city medical specialist at the New York City Department of Health and Mental Hygiene. He is the clinical assistant to the Deputy Incident Commander and lead of the Staff Immunization Justice Work Group, which is a work group within the emergency response, tasked with educating agency staff on available COVID-19 vaccines and addressing vaccine hesitancy. Dr. Watkins is a culture of health leader, a national leadership program supported by the Robert Wood Johnson Foundation, and he is really committed to health justice. Dr. Watkins, thank you so much for joining us today.
Thank you for having me. I'm happy to be here.
Wonderful. We really appreciate your willingness to answer our community's questions about the COVID-19 vaccine. So let's get right to it, shall we?
Yes.
Wonderful. So we know that there are a variety of biopharmaceutical companies developing COVID-19 vaccines. Can you tell us who they are and what are the vaccines that are currently available to the public?
All right. So there's a couple vaccines that are approved that have an emergency use authorization. The FDA has approved their vaccine products. They've studied their all of the work that they've done in the development to the safety, and they've approved it for an emergency use for this pandemic. So there's one company called Pfizer that is a really old company, been around for over 100 years, that has been making a lot of very familiar vaccines to us, like the tetanus vaccine, diphtheria, some of the pneumonia vaccines that folks are familiar with. Pfizer are parent companies that have become Pfizer, have been in the vaccine game for a while. They have created an mRNA vaccine that's available for the market. And then the other company is a newer company that's more new to the vaccine game called Moderna. That company is a more international company, and they have not made vaccines before, but they also made an mRNA vaccine. We'll go into that later, I'm sure. That is also proven to be safe and effective. So right now we have two available COVID-19 vaccines for age 18 and up for the Moderna, and age 16 and up for Pfizer. Both of them are 2 doses. And I think an encouraging thing is there's a few more that are in testing and development. So we may hear about a 3rd or 4th in the coming weeks to months.
Wonderful. Thank you so much for that. It's really important for us to understand, the history of these pharmaceutical companies and what work they have done around vaccine development in the past, and recognizing also that there may be some new ones, but are using innovative technology. So thank you for that. One of the ones that we have been hearing a lot about recently is Johnson & Johnson. And those of us in communities of color, I mean, I'm Dominican and I used to use, Johnson & Johnson products for a very long time. But there seems to be some concern about the Johnson & Johnson vaccine in our communities, particularly because of the history that we have had with products such as talcum powder. And so, there are folks that have reached out and said, should we be concerned that the FDA is rushing to approve this one as well?
I would say, you touched on history, and I think we can probably go into it a little bit further, in the conversation, but I would say just specifically about some of these companies, just understanding that these are pharmaceutical companies, and they do have a bottom line. You know, we live in a capitalist society, but
Mhm.
understanding that when the pandemic hit, it hit us all at the same time. And a lot of these companies had the infrastructure, had the science, and had the scientists to be able to respond. And so these big, you know, capitalist companies, they were I mean, unfortunately, they were the ones who were able to even take on something like this, that where they can make millions and millions of doses and make sure that it's safe and effective so quickly. So understanding that, built on a history, these folks kind of all did come together to address this one need, which was to develop a safe and effective vaccine. So
Mhm.
the Johnson and Johnson folks, yeah, they do have these histories, but I think what we should try to do when we're thinking about this is looking at this product that they've made right now, that has been developed over the last year or so, you know, that has been tested, and judge the vaccine products by the merits of the vaccine products, understanding that, you know, I don't folks didn't have time to, you know, to not do some of the things, but the FDA and a lot of folks who have been advocating for years have raised the concerns that communities do have, to make sure that they do include communities of color in
Mhm.
the trials, that they are transparent, you know, that they do follow all the safety measures that are required for things to be like delivered. And all those safety measures actually came from a lot of folks speaking up against, you know, testing and things that were done against people's consent. So it's kind of like, it's a lot of, you know, folks advocacy and outreach, trying to really like say like these things have to be made, and these big companies having to respond and be accountable to folks. So just these products that they're developing, we got to look at the products for what they are, you know, but not forget about that history.
Yes, no, thank you for that. And so I want to dive into a little bit, dive into that history a little bit, if we can, before we talk about the actual vaccine development and distribution right now. Um, can we first talk about how and why has the COVID epidemic hit Brown and Black communities the hardest? Like,
Yeah,
let's talk about the why that happened.
yeah. I think the why. I'm a part-time historian on my own time, and I think the why is kind of based in that history. I
Hmm.
think it's been proven. We know that a lot humans biologically, we are basically almost alike, except for like the things of our of our hair and skin color, all of these things. We're biologically very similar. And so there's not biological differences that are determining some of these things that we call health disparities,
Hmm.
or things that are in communities, where certain communities seem to have be more susceptible or seem to be suffering from things more than other communities. It's not a biological difference. And it's important to understand that. And I think there's these other factors, these social factors that can provide a form of immunity and protection, that historically, when folks are being marginalized, they're literally they're not given access to these life-saving things that we have as a society. And so when we talk about, you know, segregation, we talk about marginalization on the broader scale, when we talk about economic exclusion, you know, when we talk about not having access to clean food, I mean, to good food, um, fresh vegetables, you know, clean water,
Hmm.
all of these things, when you have communities that are being excluded from the good things and are being left vulnerable to all the bad things, that's how you get this situation where we are right now. And when folks don't talk about the history and really grapple with it, like on a bigger scale, that you see it repeat itself. You know, working, you know, a lot of folks who live in the South Bronx, people have lived through pandemics and epidemics. You know, we've been through the HIV crisis, and we saw how that really affected certain brown and Black communities across the city, and are still doing it in a disproportionate way. We've seen how we've been through opiate crises before in New York City, across the nation, right? And we see how folks were looking at folks who were dealing with it in the 80s and 90s, and we're like, lock them up, throw them away. But
Hmm.
now we have to heal folks, you know? So understanding, and it goes on, and community disinvestment, and folks can't even get access to care. So it's understanding that what it is a history of an exclusion and exploitation that got us in this situation in the first place.
Right.
And so when I talk about you know, hesitancy, it's like they're not confident. Folks have no reason to really be confident and trust some of these institutions and governments that have never really proven themselves trustworthy because of this history that continues today, because we see how COVID is playing out and see, unfortunately, folks in certain boroughs have worse outcomes in their hospital, so it's like keeps going on and on. Um, yeah.
Yeah, no, and Dr. Watkins, thank you so much for acknowledging that, because I think very often that is the piece that's missing, right? There's this talk about, there's this hesitancy, but it's hesitancy not only about of the research, right? So there's questions about how the vaccines were developed, but there's also questions and uncertainty about the equity, right? When you're dealing with a system that, a health system, and there are many systems that we can talk about, but when you're dealing with a health system that for a very long time hasn't been providing quality services and care to communities of color, it's hard, right? It's hard to balance and make decisions about what's right for me and my family when you're distrusting. So I really appreciate that you're acknowledging that, because I think that's one of the things that has been missing from these conversations. So thank you for that. But it also brings up another question for me, and that is that about how do you see the vaccine distribution and prioritization addressing those inequities right now? Do you see it happening?
I see, unfortunately, the way that our society and these systems are set up, they kind of set up just, it's like unwittingly, and a lot of times people just will do a thing and it's just set up and made more accessible for certain folks, certain folks who do have, material resources, who do have, who do have accessibility to like drive places and get an Uber and do, it's just set up that way. That's how the society has been built, and that's how it's kind of been going for hundreds of years. And
Mm-hmm.
so initially, I think that, I work for the health department. I wish that it was better. I wish that it was a lot more equitable. I wish that there was a time taken to say, how can we get it to the folks who need it the most? Luckily, I mean, unfortunately, there's a timing thing where the city is taking a lot of our guidance from the state. And so New York State will release a thing and we won't have that much time to respond to a thing. There's a mandate, you have to do this thing. Understanding that, there's teams of folks, there's tons of folks, and Dr. Easterling, as the lead equity officer for the department, like this is like a newer position. So we have people who, like, there's a commitment and tons of folks every day in the health department and all these agencies working to say, like, we have to meet the people. And so it's like it's a continually improving process where, like, we have to make sure that we get folks in the Bronx vaccinated who live in the Bronx. We have to talk about Harlem, we have to talk about Queens, and then, like, it's folks who are like advocating and actually working on like programs to really improve this process that was just started and made. And like, they're like, well, the vaccines are available, people can get it, but there's folks who understand that there's deeper things, and that some folks do face more barriers to get this resource that is really, necessary, and I think will help us all end the pandemic.
Right. Yes. You know, I'm going to ask you, a personal question, which is, as a person of color, as a, man of color, and a man of science, right? And I see that you may have a lot of intersectionalities, right? How do you respond yourself to, the real concerns of equity in these prioritizations?
For me, it's personal. I take
Mm-hmm.
it very personal. Before I started this work, I was working in the Bureau of STI control, and in sexually transmitted infection control, in a clinic in the Upper West Side that served West Harlem, served the Heights, Washington Heights. And, we did a lot of like HIV prevention, but also treatment. And being like an Afro Latinx, person, who was also identified as queer, like, everyone who I was diagnosing with HIV looked like me. You know, folks who were new immigrants who couldn't, didn't speak English, and I'm talking to them, and like people are like, oh my God, like I've never had a doctor who was like Black, or who was like, a dark skinned like Latin person, and all, and understanding that and just seeing how that crisis had affected our people. I was just like, I knew what was coming when this pandemic was brewing. And I said, it, like, I have to do this, and I will, like, whatever it takes, I'm gonna like stand up and meet the needs of the community. So I take it very personal. you know?
Mm-hmm.
And I've just found that, there's power in, understanding like whatever your voice is and finding that to like step into that role and to understand that however scared I am to talk in public or whatever, it doesn't matter because people need, the needs of the people need to be expressed. So I take it very personal. And I take that story and I take my history and my family's history and all the folks, I'm thinking about all the little brown faces and curly hair when I'm in these meetings. Like, folks need to get access to this just like these other folks, and they deserve it. And we need to consider them, and we need to make sure that we are doing right by them. So it's a
Mm-hmm.
very personal thing for me. But it also feels really nice because it feels like I'm part of this bigger thing, this movement of so many other people who've been doing this for hundreds of years, and it's like, that's the community, and I want to keep that energy going forward. So the next folks, when my time is done, I can pass that on too. So it's like, yeah, like you just find that energy and just like the work has to be done. And I'm here
Yeah.
for it.
Yeah, thank you. Thank you for sharing that. I have a similar journey. I was born and raised in New York City, grew up in Brownsville. And to me, it's really important to be part of the conversation and create a platform, not just that in which I am representing my community, but that I'm creating a platform for my community to step up and be able to be heard and participate in the
Yeah.
conversations.
Yeah.
Because a lot of the solutions that we're seeking can be found in the very communities that have been affected, right? And
Exactly.
so, which brings me to another question about just accessibility and prioritization. Um, when looking at the data, right? So looking at the data from last year, we know that there were very specific zip codes in New York City that were hit really hard, and those zip codes primarily were Black and Brown people. Um, Yet, when it came time to creating these prioritizations, that was not how it was decided. It wasn't decided by zip codes. It was actually decided by age. So can you give us really an understanding of how you all arrived at that decision to prioritize, the older population before prioritizing these particularly zip codes that were hardest hit?
So there's a couple factors that come into it. So there's like the 75 and up age bracket, which was like particularly hard hit across demographics, but particularly in Black and Brown communities. So there was just understanding that across just folks 75 and up, and then 65 and up, those rates, and making sure that like folks in that age bracket. So it's addressing it from like the age and just like who is the most at risk if they get infected. So there was that understanding. Most people are kind of following that same kind of like, if you're 75 and up, that's just, danger zone, watch out.
Mm-hmm.
There's that. And then there was some of the other things about folks who are that most at risk for getting infected. And so there's also understanding like those people in those higher classifications, folks, physicians and nurses and healthcare staff who are taking care of folks who have the virus. Like they're like in the, on the front lines, or, to avoid militaristic stuff, like they're out there taking care of folks. There's that, but then there's understanding this other thing where New York City is actually, we do have zip codes, or like there's like a term like madzikta, this like these like geographic locations where we have identified there's like 33 key zip like areas, geographical like neighborhoods,
Mm-hmm.
that they actually are really putting in resources. They've been doing it for testing and tracing and putting in resources. They continue that and are adding to make sure that not only are testing resources there, but making sure that we have vaccine sites there, and that we do our outreach in those zones. So it's kind of like doing like the bigger at risk, but also understanding that it's not just age, because it's like folks of that age in those zones have the risk. It's not just not every 75-year-old has the same risk
Mm-hmm.
factors. So it's trying to take that dual approach, understanding that a lot of this has come down from the state. The state will say, this is what you have to work with. Age, and then like where folks live, like folks who live in nursing homes, folks who live in homeless shelters, or like shelters for people who don't have homes,
Mm-hmm.
and other like group settings. It was that, and then people who work there and take care of those folks. And then the city kind of had to make that other factor to acknowledge, the other things that are at play in people's like health.
Mm. Um, just from, from your own experience, would you have approached this differently? Or do you think that, and I know I'm putting you on the spot right now, right? But do you think, like, when you all sit down and think about how the disbursement is happening, or the distribution is happening, do you feel like maybe we should have approached this a little differently to get a little bit more buy-in? Or do you think that you're all doing the best that you can? And I mean, I know that you're doing the best that you can, but sometimes 2020, in hindsight, right? Yeah.
2020. Oh, don't say that again. I think I'll say this. I come from a health justice, social justice, health equity background. Like, politically, it's personal, right? And so I think
Mm-hmm.
the way that I would do things probably would have a bit more intentionality, in a way that I think a lot of folks probably would feel uncomfortable with. Whereas, like, if these are the folks who are dying, go to those folks. That's first. Understanding that, there's other factors at play, and, like, like, we are the health department for the whole city, and you don't want to like
Right.
build this racial animus and all of that stuff. So there's understanding that. But I think in all things, equity and justice should be centered to it. And it's like, you can't ignore that part, because the intersection of all of these things are very important. And so I think what we got to do, we are doing the best that we can with what we have. And as long as I can keep fighting and, like, acknowledging, the needs of the folks who need it the most, and no one's like shutting me down, which is something that I am appreciative. Like, I'm not like screaming into the abyss anymore. Like, people are listening, and people are like giving me opportunities to talk about, these circumstances and what people need. And so there's that too. So I am grateful for that, to be able to elevate, this message.
That's really helpful for us to know, Dr. Watkins, knowing that, we have your voice, we have Dr. Easterling's voice, and a host of voices there at the table who are seriously pushing and approaching this work with that equity lens. I think that's really key. And so that definitely gives me a lot of encouragement, and I know it's giving our audience a lot of encouragement. So thank you for that. So let's talk a little bit about the development, right? So can you walk us through, if you can, as quickly as you can, what has been the FDA's authorization process for the vaccines that have been currently offered?
So for vaccine development, there's like a standard kind of like stepwise approach. So, they make the vaccine, they do some testing, they even do some animal trials, to make sure that they have a product that is safe and effective. And then step by step, they kind of start to introduce it to human beings. And it starts from, like, dozens of folks, then you get hundreds of folks, and they're monitoring folk. People who volunteer, they take the vaccine, and they're monitored for X amount of time. And then if that's proven safe and effective, no one's died, things are looking okay, they go to the next step. And then it gets to the point where you get to thousands. So for Pfizer, they use over 40,000 folks in the stage 3 trial. For Moderna, over like 30 something thousand folks, even across the world, were included in that number. And then at the end of that trial, with over 40,000, like, it's basically like if, like, Yankees, I don't know how many folks can fit in a stadium. Like, they basically vaccinated the equivalent of like an entire stadium full of folks, and monitored them for months to make sure it's safe and effective.
Mm-hmm.
And that's when they submitted their application for the emergency use authorization. In non-pandemic emergent times, that process of getting approved can be a lot longer, and there's a lot of red tape and bureaucracy. But there's like a mechanism built into the system where, in times of emergency, they can do an emergency use authorization where they follow all the safety steps, but some of these other, like, approval things that they have, the red tape stuff, they kind of like, look, we recognize that this thing can save lives, and to not hold up the process, but then make sure all the safety checks dotted and crossed.
Mm.
So they gave the emergency use authorization. And then there's this fourth stage of the clinical trials, where after it's been released into the public, they are still monitoring the vaccine and how it's affecting people. They're checking for safety, they're checking for efficacy. They have all these safeguards set up for all medical providers. If you have a patient or if you go into the ER with something and you had the vaccine recently, folks are supposed to report it so that it can be investigated and see, is it related to the vaccine or not? And then there's also, and there's like governmental and non-governmental organizations that are monitoring all of this safety. So like the safety stuff is like key because they know that at the end of the day, people want a product that's safe and effective.
Right, right. So can you tell us what the makeup was of the clinical trials, right, for both Moderna and the Pfizer? So can you give us a breakdown of representation? So how many were, white folks? How many were Latinx folks? How many were, Black folks, et cetera?
So the racial breakdown, I don't know the exact percentages,
Mm-hmm.
but for both of it was at least 10% and up for folks who identified as Black, and about like 15 to 20% of folks who identified as Latinx, whatever their racial identity.
Mm-hmm.
And then there was a population of East Asian folks as well in it included. But I think there was a concern because I think if we took an equitable kind of approach, it would be like, break it down evenly.
Right.
There is a history of, it's hard to recruit folks from certain communities because of the history that the pharmaceutical companies have with folks, that people don't sign up. So it wasn't as robust as I would like, but it was something that reflected closer to the percentage of the population that, in the United States.
Mm.
I
Okay.
would say, one thing I would say, because there's over 20 something million folks who have been vaccinated in the country in this new stage of vaccine, a lot more people of color have been vaccinated and are moving and living in the world with the vaccine. And we can also, and with this safety monitoring, we can find out, if a lot of brown people are going, there's an investigation that is done to see what is going on. Is this somehow connected? And there's people who are disease investigators and and medication investigators who will do that research to kind of find out what's going on.
Okay, thank you. And now, do you happen to know if any of the folks that were part of the clinical trials, if they had comorbidities, right? Because I think a lot of our community members, and I see some questions that are coming in right now, have some comorbidities, right? And they haven't gone to get the vaccine because they weren't sure if folks with similar comorbidities like the ones that they have were included in the clinical trials. So are you able to share a little bit of that data if you have it?
I don't have the data on hand, but it's readily available.
Okay.
So the FDA, when in their part of their emergency use authorization, they kind of they go through the whole process and kind of summarize it, and that's available. And it's available on the CDC website. It's available on the FDA website, and also the companies themselves have that data available. But when they set up these studies, what they do is they want a good sample size that can reflect the population as much. So they have a large percentage of folks who are 65 and older, and they want folks who kind of do have, they're not going to exclude folks who have, history of heart disease or history of other, comorbidities, because we know that is very, prominent in the community overall. So they want to have a broad representation of the population in the country, so that they can have that data in, a broader, like a better representation. You want a better representation to kind of draw some conclusions from that.
Mm-hmm. Okay, so we're getting a couple of questions here, so I'm going to grab them from the Q&A. One has to do with folks that have received the vaccines. So how many of the people that received the vaccines had side effects, and what were they?
So most common, there's a few pretty common side effects that folks experience. The most common one is soreness or discomfort at the site where you get it. That's like 90-something%. It's a shot, you're going to feel that. A lot of folks kind of do have like some soreness in the arm. When I got my vaccines, I did have soreness in the arm for like a day or two, but it wasn't to the point where I felt like I needed to take like a medication for it or like call out work. Another common side effect that people experience is fatigue. People feel really tired. I didn't feel that, but I know a lot of my colleagues in medicine and some, like, I have an uncle in Florida who got it, and he was like, felt like he had like a bag of rocks on his back, just tired. But that went away after about a day too. Other than that, some people get like muscle like aches and pains for like a couple of days. Some folks, what else? Some folks kind of like some folks said that they felt like they caught like they had COVID, like felt like something was happening. But all of those symptoms went away within a couple of days. I
Okay.
think it's important to know that some of those symptoms that you do experience are because of the injection, but also because of what we call a primary immune response, which is what we want. The vaccine is supposed to help your body create an immune response so your body can generate antibodies. And so part of that process, sometimes activating your immune system can make you kind of feel achy. And every time our immune systems are activated, in just walking around, it's because we are infected with something. And so understanding that the vaccine induces the results of it gives you the antibodies that you want, but it skips the part where you actually get infected because there's no virus in it, there's no infectious agent in it. And I think that's the key to understand that you may feel that, but that's part of your body like mounting an immune response.
And so you want you want to see that happen. Is that what we do? We want, not that we want folks to feel, sore arms, but understanding that sometimes a reaction is needed to make sure that it's working.
Yeah. So
Okay.
you want an immune response, and for some folks, if you have a robust immune response, if your immune system is really kicking in, sometimes you'll feel that.
Mm.
So you don't have to go through all of that to get immunity, but sometimes some people do. So if you do have that, just like, okay, this was expected, this was part of the response. My body is really trying to build immunity, and it's kind of like that. Like that's what your body's trying to mount that immune response.
Okay, wonderful. One other question that just came up. There's been a lot of talk about, chips, right? That the vaccines have some sort of built-in chip that track people's biology, their chemistry, and so that there's real concern about that. Can you help us debunk this myth?
Yeah, so these vaccines, they are technologically advanced, but they do not have that level of technological advancement. There's basically three major components to the vaccine. There's the mRNA component, this genetic component. Again, our bodies are all constantly using mRNA. So they've created a little strand of mRNA that can teach our bodies to produce something that the COVID virus has. So without using the virus at all, our bodies can produce a thing that will make us make an immune response to the virus. One of the other things they have is something called lipids. Lipids are one of the basic fundament building blocks of life. We have lipids, we eat lipids as fat and oils. There's other types of lipids that exist in our cells. And so the lipids that are in the vaccine are to protect the mRNA and also to help our bodies absorb the vaccine. The other of the three components is like saline. That's like the liquid part. And a lot of folks are familiar with saline. Like you get an IV, that IV bag contains normal saline. And that's just like mostly just like water and minerals that help create like a liquid substance that make it liquid, that also match your pH and your body chemistry, so that when you get a medication, you don't have a reaction. So like also with like antibiotics, we use normal saline, and a lot of other vaccines, we use normal saline. So those are the three main components. There's no chips at all, or no kind of tracking in the vaccine at all.
Sorry about that. My mute button went on. Okay, there's a couple of other questions that are coming up as a follow-up to what you just shared. Are there folks that did not feel anything at all after receiving the vaccination?
Yeah, I mean, a lot of folks who didn't feel anything. I mean, getting an injection and a needle in your arm, you're gonna feel that. I would say I probably felt minimal symptoms, and I think a lot of folks will feel like the minimal.
Okay, great. Another question that's coming in. If you already have experienced COVID, do you need to get vaccinated?
I would say yes, because folks who have been infected can get reinfected. It's happened. We're seeing that happen. And we also know that folks who get infected may not have had symptoms, but had antibodies, that those antibodies can also wear out over time. And so think about the vaccine as like a boost, like it's giving you immunity, the thing that you want, and a protection without having to go through clinical illness, without having to be infected or actually come in contact with the virus itself. So it's like it's an added bonus.
Okay, thank you. Another question that we're getting is, do the vaccines interact with medications? Some of
These
our folks
vaccine
have, take medications for a variety of different things. So do they interact?
so these vaccines are very safe. And because of the nature of how these vaccines are created, with just that genetic component, and like the lipids, it's very like minimal product, if to kind of make sense of, like it's not going to interact much with a lot of things. I would say, if you're on meds, talk to your medical provider so they can kind of review the list and double check. I think that's important. But I think just understanding by the way that the vaccines are designed to work, by going into the arm, going into the muscle, into like the cells, the immune cells, to create this response. The big thing is like the vaccine itself, like the genetic material, the mRNA, it does not last very long in our bodies, because our bodies are designed to use mRNA and then dissolve it. So our bodies will clear that mRNA out of our bodies within a matter of hours to about a day, that the mRNA is going to be broken down. So it's not like lingering around and interacting with all this other stuff. Once the mRNA has gotten into the cell and your cell starts doing what it needs to do, eventually it's done. It reads the message, and it kind of like, it's like you get a DM that vanishes. You get the message and then it goes away.
That's really interesting. I didn't know that. Thank you. Thank you for sharing that. Another question that has come up, what if you choose not to get the vaccine? Will at some point it be mandated in New York State?
I cannot tell the future and say that. I would say that things that have emergency use authorization cannot be mandated. And I would just say, at this time, I don't think, at this time, it's not an option.
Mm-hmm. Okay. Okay. Thank you. Okay. Let's see. There are some folks that are expectant parents. And so one of the questions that we received is, I am expecting and have, I am expecting, but there's not enough data on how the vaccine would affect my baby. What are the potential risks for my baby if I get it, if I get the vaccine versus if I don't?
So I can address it from the don't. So unfortunately, people who are pregnant carry a higher risk of bad outcomes if you get infected with COVID-19. Being pregnant can alter the way your body's functioning. It can alter your your lungs don't work as well. Like, you can feel short of breath. It changes your body chemistry when you become pregnant. And unfortunately, pregnant folks are at higher risk from severe illness if they get infected with COVID. So understanding that there's a higher risk to yourself and your baby from getting the virus. So then the other question is, so what do I do, and what do I think about the vaccine? So there's a few bodies, bodies that exist of the leading experts in different medical fields. And so the American College of Obstetricians and Gynecologists, they've been looking at this. They've come together. They've held conferences to try to understand how do we go about this. And they themselves have looked at the evidence, and they say that the evidence shows that it seems safe and effective, that they would recommend that people who are birthing or pregnant strongly consider it, and that they should not be denied the vaccine, understanding the risk that exists for pregnant folks that the virus has. So I think this is a conversation to be had with your medical provider, and your family, trusted folks, to kind of figure out the risks and the benefits. But just understanding that when it's not a pre-existing condition, but being pregnant puts you in a status where you are more vulnerable to this deadly virus that passes easily through the air from person to person.
Okay. And so folks that are expecting should talk with their primary doctor about, the benefits of the vaccine, and also taking into consideration what, if they have gestational diabetes, for example. So making sure that they have these conversations to make informed decisions.
Yeah.
Okay, thank you for that. Another question that we have here: is there a third booster that must follow the first two vaccines for Moderna and Pfizer? So this is a two-part question. And then the Johnson & Johnson vaccine will allegedly only require one shot. Is that true? And if so, how soon will this be possible and available?
So there is no third part to the series for Pfizer or Moderna. But what I will say is understanding how viruses work and things mutate or they change over time. We see this all the time. We see this with, I think most commonly like the influenza. Each year it changes and mutates. We're seeing some mutations going on in the COVID, right? It's been over a year, and we're seeing, in places where there's a lot of spread, we've seen mutations coming out of South Africa, in Brazil, in the UK. So mutations can happen. So depending on what if these mutations are protective for the virus, meaning these mutations help the virus stay alive, or if they're more dangerous for humans, meaning that the virus can kill us more, and also the fact that who knows, like if the virus is protected, meaning our vaccines don't work anymore against it, there is the option that we may have to, go down a pathway similar to the influenza vaccine and maybe have to adjust to meet the needs, or to actually be able to protect against these new variants. So it's possible that there may have to be an adjustment in the future to respond to what's going on. But, they would be using the same, really high technology and really good resources that we already have in place, infrastructure in place, to kind of make those adjustments. We're doing it with the flu already.
Mm-hmm.
Johnson & Johnson is a one-shot regimen. There are studies they're trying to see they're investigating for like a two-shot, but I think they're going to release it as a one-shot. They're trying to get approval right now. I know in the UK, I saw that they were thinking in March. We'll see where the process is in the United States. So maybe next month we'll see some movement on this third vaccine that is a one dose regimen so far.
Okay, thank you. That's helpful. Because there are a lot of questions about, the longevity of the vaccines, right? Will people be protected long-term or not? But it's wonderful to hear that you all are tracking that information and monitoring it to make those decisions and determinations later on. One of the things that folks have also been wondering about relates to the distribution, right? So can you talk a little bit about the outreach that's being done in terms of outreach for the hardest hit areas in New York?
So there's multiple ways to outreach, and I think there's like a lot of folks with feet on the ground, on the pavement. Folks are out in communities, handing out like flyers and passing out information and canvassing communities and spreading the information that way. They're working with a lot of community and faith-based organizations around raising awareness, addressing concerns, and letting folks know about the vaccines available. We're actually working with some community partners. They're, bit by bit, they're adding more and more to actually work with some of these community partners to actually set up appointments, so that block off some appointments so that they can get the folks who they serve on appointments. I know it's really difficult and frustrating, but like they're working out ways to help reserve spots. So that's a huge thing. There's also some outreach in hard hit communities, especially in the NYCHA communities, where they have this plan. They're trying to hit all these major NYCHA buildings that serve where seniors live, to get folks vaccinated. So they're knocking on doors and holding these vaccine events for folks in these buildings to get the vaccine. And then there's just other things, like there's a lot of folks who are working with community-based organizations to train them on vaccines so that they can actually be, out in the community having these conversations as well. There's folks like me who are talking to a lot of folks multiple times a day in town halls, community conversations. And then there's just like the bigger push around the city for like these mass vaccine sites. So folks have seen in some of the major stadiums where this is happening, but they're also working with hospitals. They're also working with clinics, and there's a new program that was started recently with pharmacies. So the Biden administration is sending doses to pharmacies. I forget which brands, which ones, but it's all online. They're talking about it, and these pharmacies are going to be like additional points of access for vaccine. For I know seniors, to start out, they want to make sure that the seniors get vaccinated. But yeah, so
Right.
there's a lot of good work going on.
Okay, so it seems like it's evolving into the same approach that we have with the flu vaccine, right? Where any of us can just go to our CVS and get the shot, which is really helpful, because then you're able to gain access to a larger number of the population. There's another question that just came in, which relates to the previous topic that we were just talking about, related to the clinical trials. Although there were 43,548 trial participants in the Pfizer vaccine's phase 3 trial, their calculation of effectiveness is based on a total of 170 participants. Shouldn't this be a concern about the language used about its effectiveness?
So the effectiveness that they're calculating is effectiveness of around symptoms. So they're using that kind of like as a placeholder, because you can't really find out how many infections you prevented. Like you can't quantify that or qualify that. So it's basically they're like, in the folks in the trial who were infected and who were found to be infected, what did that mean? And so they're doing that calculation, like the people who were infected, were they in the control? Were they folks who were general population who did not receive the intervention, did not receive the vaccine, compared to folks who were vaccinated? And that's kind of where they're calculating. That's where they're doing that number to see of that 100 something, how many folks were vaccinated. And it was a very small number. And all those people who did turn out to be infected had very minimal to no symptoms, which is actually the more like real life thing that you worry about. Essentially, what the vaccine is making, but can make, we think that it does prevent, right? But if you do get it, it makes you like an asymptomatic person, so you don't die from it, which is an endpoint that we all want. Nobody wants to die from this thing. There's more research being done to try to figure out the actual like preventative thing, but understanding that it's a game changer in that way, that death rates from this thing are like 1 to 2 in 100, right? So if we're able to decrease the death rate by vaccinating folks, so folks, if they do get infected, that they're not getting sick and dying, that's a big part of it too.
Right. That's an important end goal. Can you tell us, there's one question here, let me see. Can people who have been vaccinated still infect people even though they're not ill?
So yeah, that's what I was touching on a bit, where some folks who are vaccinated were found to be carrying it, and so they're trying to understand what that actually means. But I think that's why folks should still be wearing masks, should still be trying to do the physical distancing, should still like be cautious and vigilant, because at that point it's you yourself are protected, right? The vaccine protects you, but it may not do that other thing that's also necessary of protecting other folks in the community, folks who you're living and working with, and it's like it seems like those folks may kind of be like turned into like a vaccinated but like an asymptomatic carrier. And you wouldn't want that. You wouldn't want to like do some asymptomatic spread just because you were vaccinated, and you're good because you've been vaccinated, but you don't want to be you don't want to pass that to someone unwittingly. Yeah.
Right. Okay. Some questions here about distribution. What is the expected rollout for second wave of eligible people to get the vaccine?
So by the 15th, they're going to broadly include people with underlying medical conditions. You can check the New York City Department of Health website there's like COVID data and the COVID eligibility. You can click on that and they kind of have like a timeline. So the 15th is where it opens up for underlying conditions, and breaks it down by just like organ system, like people with like kidney issues, people with lung issues. So it's broken down that way. And they also have some guidance. They're working with the state to figure out what is required for you to have that documentation to actually get the vaccine at the sites. So that's going to come out hopefully next week, where there'll kind of be a little bit more clarity on like how do you prove that you have high blood pressure or
Mhm.
diabetes.
And how is preparation happening on the back end, right? So at all of these different health, clinics and hospitals and stadiums, et cetera, are you all simultaneously preparing to expand the number of people that are available to administer the vaccine and to monitor folks? Like, how is that working on the back end?
The limiting factor, which I want everyone to understand, is the available vaccine, the vaccine supply. It's a matter of supply and demand.
Mhm.
Unfortunately, a lot of things like that are in this country, but it's a matter of supply and demand. We have the infrastructure to vaccinate over like 500,000 folks in New York City in a week with the infrastructure that we have, working with hospitals and with pharmacies and places that are able to do it. We could vaccinate that many people. Unfortunately, we're not getting a supply to meet that demand, and so that's kind of why we're severely limited. Hopefully, with the new administration making that commitment to rev up things, with the new vaccines becoming available, I think that will change the game, and then we could actually use all of the infrastructure that we have to vaccinate folks. But the limiting thing is the supply.
Okay. Dr. Watkins, we're getting lots of questions here from the audience. Here we go. I'm going to send them at you really rapidly.
Okay, rapid fire.
Rapid fire. Here we go. Should one be tested before receiving a vaccine?
You don't need to.
Okay. There we go, folks. If you get the vaccine, can you take an antibody test to ensure it was effective? I have immune issues.
You can, but it's not required. I would talk to your provider about that.
Okay. Another question we have, will a COVID vaccine be available for kids in the future?
I think pretty soon. There's already tests underway for people 12 years and up for both Pfizer and Moderna. Hopefully in the coming months, we'll see the results.
Okay. All right. Let me see. Is there another one coming? There is another one. Let's see. So what is the timeline for the rest of us to be vaccinated? Those of us that don't have autoimmune issues or any comorbidities, what do you see the timeline to be?
That's supply. I think if the supply met the demand, then it would be everyone can get it. They've had to do this priority and kind of limit it so that we can get the folks who are the most at risk and the most vulnerable. But I think when the supply meets that, and if we have like hundreds of millions of vaccine doses available across the country, then it would just be we're not doing this eligibility thing for the flu vaccine, right? Because there's just enough out there.
Mhm.
So eventually, when the supply meets, then everyone can get, because that's where we want it.
Okay. There was some talk that we've heard from Governor Cuomo that he was potentially trying to purchase the vaccines directly from the pharmaceutical companies, but that has shifted in recent weeks. So now he's just waiting for supply to come directly from the federal government.
Yeah, I think that's kind of where it's going. I think before the new administration came in, there was a very much like a patchwork of people fending for themselves. And I think with a new kind of like a more unified, like, overview approach to kind of really make sure that, that folks are getting a supply that kind of meets their population needs, that's kind of like, it's a more focused and more like organized approach that the new administration's taking.
Okay, wonderful. A couple of more questions here. How long do you believe before we reach herd immunity?
Depends on how long it takes to get folks vaccinated and to get enough of the supply out there.
Okay, so a follow-up to that question, what would be the optimal number of folks that would need
So,
to be vaccinated in order to reach herd immunity?
so let's go by percentage, and they're saying like herd immunity when they talk like academically, it's like around like 70+%
Mm,
of a population to be vaccinated to have this status of herd immunity, where there's not enough people who can get infected or who are infected to spread to protect folks who are unable to be infected.
okay. Another question here. Do you believe most organizations and companies can go back to a pre-pandemic way of life, or has the pandemic changed work-life culture?
I hope it changes work life culture, because I think that it's been very brutal on folks. And I think we were living in a world where if folks are sick, you're still like expected to go in and you can affect the whole office. So I hope that there's some positive changes in the work life culture. I hope that the pandemic also made a lot of work life things different because now we can, it's more accessible. There was times where we couldn't even talk about Zooming for work, and it's like you have to come in, snowstorm, whatever. So there's some positives that can come out. And I hope some of those positives for work life can actually take place or set in.
No, that's very well put. Thank you, Dr. Watkins. I think, what we're realizing, and I say this to my team all the time, is that we're all interconnected, right? And that, my health depends on your health just as much as me taking care of myself. I also have to be able to think about, what am I doing that could impact you, right, in this new reality that we're living in. And so I do agree that we need to think about the work-life balance in a different way, and that there are some things that we've learned, some really valuable lessons that we've learned that I hope we can continue to implement going forward. So I see, let me see, Andrew, do we have additional questions coming up? Oh, there's a pause. Okay. So let me ask you just a couple of additional questions that were sent to us earlier before we began. And that is, what do you think that we should all be doing to protect ourselves and our families right now? What recommendations would you have for all of us that are listening and watching?
I think the biggest recommendations is just to really ground yourself in the history and understanding that this is like we're people living in a world that can be dangerous and scary at times, but other people who look like us have lived through dark and tough and testing times, and now it's our turn. And we have to step up and kind of be vigilant and help lift up someone who needs the help, and make that phone call to check on someone, and off mutual aid. It's about really trying to understand what is community and getting back to that, be it like your office community or like your faith group community, whatever that is, like really figuring out what that is and understanding that we are interconnected and in this together, and helping to support and bring another person up through it, and taking care of yourself, also because self-care is important, and also because you don't also want to like burden someone by like you getting sick and then someone has to it's all of that, and understanding that the only way we get out of this is together. And really like thinking about what that really means, and trying to, I guess, something, I mean, people may feel uncomfortable with it, but I think our society, we've kind of turned away from community and turned away from love, and returning to that, like what does that really look like, like how does it mean to like care for someone and want them to be good, and want them to like mentally and spiritually kind of like feel be good, and really take the time to focus on that as well too, because there's a lot of complex trauma going on, and people are really these kids are dealing with it, these youths are dealing with it, single parents, and it's older people, a lot of folks are dealing with a lot, and I think just taking the time to think about that in all of this is important.
Thank you, Dr. Watkins. That was beautifully put, and it really illustrates the work that we do at Power of Two, where we really focus on the social connections as a way of really healing ourselves from trauma, right? And not forgetting that we have a really rich culture in community, right? And it's that community that helps us to heal, helps us to stay healthy, helps us to thrive and really reach our full potential. And it's all going back to that interconnectedness, and really moving away from the personal responsibility and moving toward a more holistic approach to health and healing. So thank you for sharing that. With just a couple of more minutes left, and as we conclude today's conversation, Dr. Watkins, I wonder if you can share with us a call to action for us as community leaders, but also for the larger community and those folks that are listening right now. What is your call to action for all of us?
I think my call to action is understanding there's two conversations that are going on around the pandemic and the vaccine, right? I think this pandemic is the thing that all hit us at the same time, and that it knocked a lot of us off. Like we were just like, this was a thing that no one really was expecting, really threw us off. And I think that this vaccine coming is part of a long history of vaccines. Vaccines have gotten our cultures and societies out of a lot of dark times. There's a lot of older folks who lived through polio, where children were being paralyzed for life. And we lived through smallpox. Smallpox was eradicated from the world because, based on science learned from an enslaved West African man, and we were able to now eradicate smallpox in the world. And so this is a part of our history too, vaccines. But now we're working with most up-to-date scientific, this is some 2021 vaccine technology that we're using. It's not just flying cars and the Jetsons. It's safe and effective vaccines that can be produced for the entire world, that can help us get through something like this. And we have to look at that vaccine for what it is, and for like this thing that could be a thing that could really save us. The second part of that conversation is understanding that when we're talking about this thing of not having that confidence and that distrust, that it is very real and it needs to be addressed. It's worthy of addressing. We have to really critically analyze these things and look at it. Why are people of color dying more from this thing? Why have we been dying more from all these other things? Why did we have a global uprising and a movement for Black lives during all of this? That's the second part of the discussion. And that we have to hold people accountable. When we talk about equity, we have to make it personal, and we have to take that, so for the community, I would say for this part, it's that knowing that what you're feeling is real. You're not playing the victim card. There's some real stuff that needs to be addressed, and that has to be addressed. And hopefully, as part of all of these conversations around the vaccine and the virus, hopefully we can continue this same energy to talk about these other things, because there's a lot of other things that are making our communities sick,
Right. That's right.
And so,
yeah, Dr. Watkins, thank you. Thank you for joining us today. Thank you for your candor, your honesty, and thank you for ensuring that our perspectives and voices are heard in the work, and for all that you are doing for our communities every day. We're incredibly grateful to you. Thank you. To all of you watching and listening, we will post this video on all of our social media platforms. We will make it available in Spanish as well. We will also post information about the vaccines, the distribution sites, how to schedule appointments, and a whole lot more on all of our social media platforms. And I just want to leave you with a quote from Kathleen Sebelius, who was the former United States Secretary of Health and Human Services under President Obama. And she said that in many ways, human health is the great global connector. And so please wear your masks, please practice physical distancing, get tested, and please consider the vaccines. Everyone, please stay healthy. Dr. Watkins, thank you for your time. Take care, everyone.
Thanks for having me.